Good morning, everyone. My name is Isa, and I'm one of the BGY residents at St. John Hospital. And this is my first poster presentation at the ECP under the name of Humoral Hypercalcemia of Malignancy and a usual presentation of Paraneoplastic syndrome of invasive metastatic papillary urothelial cell cancer carcinoma. I was honored to work with Churi and also the chief resident, Huber, who did actually great work on this and helped me a lot in it. So we're going to start first with the introduction, and all of us know that the hypercalcemia is one of the common features of malignancy, and there are many mechanisms of hypercalcemia, and this includes bony metastasis as well as production of vitamin D or even PTH RB production. There are well-known cancer that produce the PTHRB, and this include lung cancer, ovarian cancer, breast cancer, but it is rarely described and rarely a reported phenomenon in people who have a bladder cancer. So according to that, we would like to present this case with metastatic papillary urothelial cell cancer and presenting with humoral hypercalcemia of malignancy. He is 79 years old, Caucasian male, past medical history of papillary transitional cell carcinoma, and they presented to the hospital because of weakness as well as altered mental status. He also complained of lower extremity pain at the left side of the body, at the left leg, and also lower back pain. Physical exam, the patient was confused, and the initial workup of the patient showed that he has a calcium level of 18.3. We started him on IV fluids, zoledronic acid, calcitonin, and we appreciated improvement of his mental status as well as the of the calcium level. We also did when we did the CT scan of the abdomen and pelvis, we found that the patient has sclerotic and lytic lesions of the spine, and you can see here the yellow arrow is pointing toward the lytic lesions, mostly involving the L3 vertebra, as well as we have sclerotic lesion at the S1 vertebra, along with prevertebral lymphadenopathy. So there was also on the labs we had low phosphorus level. We didn't have an explanation of this low phosphorus level, despite we have been trying to replace it multiple times, but it was low. When we looked also at the vitamin D levels, we found that the vitamin D is low, the PTH also is low. So for this reason, we decided to go and check for the PTHRP for the patient, which came actually high, like around 8.6, confirming that the patient has a paraneoplastic humoral hypercalcemia of malignancy. We did refer the patient for a hemonc for further follow-up and for further management. So according to that, we do believe that humoral hypercalcemia, this ends us to the discussion that humoral hypercalcemia of malignancy is caused by ectopic production of PTHRP, and stimulates the osteoclast to release the bone calcium. And as I said in the beginning, there are many mechanisms behind that, includes the metastasis, PTH production, vitamin D production, and the therapy for that we usually use IV fluids as well as the bisphosphonates and the calcitonin. So the message that I want everyone to take home from this case is just make a broad differential diagnosis, and if the labs did not actually fit with the clinical scenario or clinical situation, go and test for other go and do other tests to confirm your suspicions. And in this case, we did the PTHRB and it came back positive. Thank you so much.